Welcome to this Step 3 review on Common Pediatric Infections. This video is brought to you by Roadmap to Residency, your home for expert tutors and residency advisors. Today we are not going to reteach every detail of pediatric infectious disease. Instead, we are going to train you to read the question stem like a test writer, recognize the high-yield patterns, and pick the right answer quickly. We will cover ear infections and sore throats, the barking cough of croup and the wheezing of bronchiolitis, the classic viral rashes, and how to choose the right antibiotic for a child. If you find this helpful, please like the video and subscribe to the channel, and visit roadmaptoresidency.com to work with our tutors and advisors. Let us get started. Here is what we are going to cover today. First, we will decode the way pediatric infection vignettes are written, from the painful ear and the sore throat to the barking cough and the wheezing infant, plus the classic viral rashes. Second, we will build a simple mindset for choosing the right antibiotic for a child, or choosing no antibiotic at all, using good stewardship thinking. Third, we will walk through full practice questions together and explain why every single answer choice is right or wrong. The goal is strategy, not memorization. Use this video alongside your question bank and a trusted pediatrics review resource so that the underlying facts are anchored while you sharpen how you actually take the test. Our first strategy is to find the age and the timeline before anything else. In pediatric infection stems, the child's age narrows the diagnosis immediately. A barking cough in a toddler usually means croup, but the same cough in a very young infant who is feeding poorly should worry you much more. So read the age first, then read the rest of the stem hunting for what fits that age group. Next, map the symptom timeline. Count how many days the child has been sick and notice whether things are getting better or worse. A sore throat for 3 days with fever reads very differently than a runny nose for 10 days that never improved. Very often, the timeline is the single clue that separates a viral illness you can simply reassure from a bacterial one that actually needs treatment. Train yourself to grab the age and the timeline every single time. Strategy 2 is the viral versus bacterial mindset, and this is the shift that wins pediatric infection questions. Start from the default that most childhood infections are viral and need only supportive care. That means fluids, fever control, suctioning a stuffy nose, and clear instructions on when to come back. When a well-appearing child has a classic viral picture, the better answer is usually reassurance and symptom care, not an antibiotic and not a big workup. Be suspicious of any choice that reaches for antibiotics or imaging in a stable, well-appearing child. Then remember the second half of the rule. An antibiotic has to be earned by specific findings, not handed out for fever alone. Look for the detail that justifies treatment, such as a bulging eardrum, a positive strep test, or a clear bacterial pattern. When two choices both look reasonable, pick the one that treats a confirmed bacterial infection and avoids antibiotics when the picture is viral. Strategy 3 is antibiotic selection and stewardship, which shows up constantly in pediatric questions. First, reach for first-line therapy first. For ear infections and strep throat in a child, the first-line answer is usually a narrow drug such as amoxicillin. The exam rewards the standard first-line agent over a broad or second-line drug unless the stem gives you a clear reason to switch. Second, use the allergy and the history. A documented severe penicillin allergy, a recent treatment failure, or recent antibiotic use can change the right choice, so match the drug to the specific child described rather than grabbing the broadest option. Third, beware the broad-spectrum trap. Question writers love to plant a powerful, broad-spectrum drug that feels safe because it covers everything. For a routine childhood infection, that choice is usually wrong because it drives resistance and side effects. Choose the narrowest drug that reliably covers the likely organism. Let us work through our first practice question, and this one tests the painful ear. A 2-year-old girl comes to the clinic with 1 day of right ear pain and fever after several days of a cold. Importantly, she is still drinking and playful. On exam, the right eardrum is bulging, red, and immobile. She has no drug allergies and has not taken antibiotics recently. The question asks for the most appropriate next step in management. Your choices are: Option A, reassure and treat with pain control only. Option B, prescribe oral amoxicillin. Option C, prescribe oral azithromycin. Option D, refer to an ear, nose, and throat specialist for ear tubes. Pause here and use the age, the timeline, and the viral versus bacterial mindset to make your choice before we walk through the answer together. Let us break this down. First, spot the pattern. We have a bulging, red, immobile eardrum together with ear pain and fever in a young child. That combination is the classic picture of an acute middle ear infection, and the child is well appearing with no allergy and no recent antibiotics. Next, apply the rule. This is the bacterial picture that actually earns an antibiotic, and the first-line therapy for a child with no penicillin allergy is oral amoxicillin. It is narrow, effective, and the standard of care, so option B is correct. Now eliminate the wrong answers. Pain control alone, option A, undertreats a confirmed bacterial infection in a young child with a clearly bulging drum. Azithromycin, option C, is a second-line drug we save for a true penicillin allergy. Referral for ear tubes, option D, is for recurrent or persistent disease, not a first episode. The answer is prescribe oral amoxicillin. Here is our second practice question, and it features the barking cough. A 2-year-old boy is brought in during the night with a barking, seal-like cough and a hoarse voice for one day. He has a low-grade fever and a harsh sound when breathing in, but only when he is upset. Between coughing spells, he is calm, alert, drinking, and not drooling, and his oxygen level is normal. The question asks for the most appropriate next step in management. Your options are, option A, give a dose of oral corticosteroid and observe. Option B, start intravenous antibiotics for the airway. Option C, take the child urgently to the operating room for airway inspection. Option D, order a computed tomography scan of the neck. Notice the reassuring details in this stem. Pause, decide what this barking cough represents, and pick your answer before we work through it. Let us work through this answer. First, spot the pattern. A barking, seal-like cough with a hoarse voice and harsh breathing in a toddler is croup, a viral illness of the upper airway. The stem is quietly reassuring you that this is the mild form because the child is calm, drinking, not drooling, and the harsh sound shows up only when he gets upset. Mild croup is managed with a single dose of oral corticosteroid and observation, and many children also get cool mist for comfort, so option A is correct. Now eliminate the dangerous mimics. If the child were drooling, refusing to swallow, and looking toxic, you would worry about a throat space infection that needs the operating room. But those features are absent here, so option C is wrong. Antibiotics, option B, do not treat this viral illness. A neck scan, option D, only adds cost and radiation without changing management in a stable child. The answer is, give a dose of oral corticosteroid and observe. Now let us contrast bronchiolitis with pneumonia, because the exam loves the wheezing infant. Picture an infant under 1 year of age who has a few days of runny nose, and then develops wheezing, fast breathing, and widespread crackles during the winter season. That is the classic bronchiolitis stem, and the illness is viral. The best answer is supportive care, which means fluids, gentle suctioning, and oxygen if the level drops, while you avoid routine antibiotics, routine steroids, and routine chest films. Now watch the distractors. The stem will often tempt you with a chest film, with antibiotics, or with a breathing treatment, and for typical bronchiolitis, these add very little. You only shift your thinking toward pneumonia when the stem gives you focal crackles in one area, a high fever, and a sicker-looking child. Finally, let the setting and the oxygen level tell you whether this infant can go home or needs to stay for monitoring. Here is our third practice question, and it features the sore throat. A 7-year-old girl has 2 days of sore throat and fever. Notice that she has no cough and no runny nose. On exam, she has tender, swollen neck glands and white patches on enlarged tonsils. A rapid strep test done in the office is positive, and she has no drug allergies. The question asks for the most appropriate next step in management. Your choices are: option A, prescribe oral amoxicillin. Option B, reassure that this is viral and treat symptoms only. Option C, prescribe a broad-spectrum oral fluoroquinolone. Option D, order a throat culture and wait before any treatment. Use the pattern of fever and sore throat without cough, plus that positive test, and choose your answer before we go through it together. Let us break down this answer. First, confirm then treat. Fever and a sore throat with no cough, along with tender neck glands and white patches on the tonsils, point strongly to strep throat, and the positive rapid test confirms the diagnosis. Confirmed strep throat is treated in part to prevent rheumatic heart disease, and the first-line therapy in a child with no allergy is oral amoxicillin or penicillin, so option A is correct. Now the key distinction among the wrong answers. Calling this viral, option B, ignores a positive test and the real risk of complications. A fluoroquinolone, option C, is the broad-spectrum trap, and it is both wrong and unsafe for a routine pediatric throat infection. Ordering a culture and waiting, option D, is unnecessary because the rapid test is already positive and gives you your answer. The answer is prescribe oral amoxicillin. Here is a high-yield example for the viral rashes, which is to read the rash by its pattern and timing rather than memorizing every detail. Learn the classic pictures. A bright red rash on both cheeks that looks like a slapped face suggests fifth disease. A high fever for about 3 days that suddenly breaks, followed by a rash that appears just as the child starts to improve, suggests roseola. Tiny white spots inside the mouth before a rash that spreads downward from the face, especially in a child who is not vaccinated, suggests measles. Now the test-taking move. Match the timing of the fever and the rash to the classic picture, then choose supportive care for these common viral rashes. Always check the vaccination history, because a missing vaccine is often the clue that points you to measles, and save specific testing and public health reporting for the stems that clearly describe it. That wraps up our review of common pediatric infections. Remember the core moves we practiced today. Read the age and the timeline first. Default to viral and supportive care, and make the antibiotic be earned by specific findings. When you do treat, reach for narrow first-line therapy and avoid the broad-spectrum trap. Drill these patterns in your question bank until they are automatic. Read every explanation even when you answered correctly, and confirm each antibiotic choice in a trusted pediatrics review resource. If this video helped you, please like and subscribe for more board review content. And to work with our expert tutors and residency advisors on a personalized plan, visit roadmaptoresidency.com. Good luck on your exam, and we will see you in the next one.